What is the role of CT imaging in Meniere's disease? Hello and welcome to the AJNR Podcast. I'm your host, Francis Deng. I'm a neuroradiologist at Johns Hopkins. And today we're diving into a fascinating topic that bridges the gap between neuroradiology, otology, as well as embryology. We are discussing a new study in the January 2026 issue about the postnatal development of the vestibular aqueduct trajectory on CT. And I'm glad to be joined by my friend and mentor, Amy Juliano, who is the first author of this article. Dr. Juliano is an associate professor of radiology at Harvard Medical School, and she's also the senior editor of the head and neck imaging section of the AJNR. Welcome, Amy.
Francis, thank you.
Amy, I want to start off with some context for listeners who probably haven't thought about Meniere's disease since medical school when we first learned about it. What is Meniere's disease and how might patients present to clinical attention?
Yeah, so going back a couple hundreds of years now, back in the day, there was a time when whenever people felt vertigo, it was considered a congestion of the brain. And people were classified as having apoplectiform cerebral congestion. And it was Prosper Menière in the 1860s. And it was his genius to say, wait a minute, I think some of these patients with vertigo, but also tinnitus and also hearing loss, that may actually not have a brain problem, and it may be a problem in the ear. So that was really the beginning of this identification of this disease, which was named after him, called Meniere's disease. So the classic constellation of symptoms for someone with Meniere's disease is vertigo. They get dizziness so bad that they get drop attacks, and they end up not being able to drive. So some of them lose the ability to go places on their own. They sometimes can be really pretty debilitated. The second is tinnitus, so ringing in the ears. And the third is they get this hearing loss, and it's basically sensor neural. It can fluctuate, but the general course over time, it's a decline. So over time, there may be little blips and such, but the slope overall is a decline. So that's the constellation of findings of Meniere's disease.
I remember also learning in medical school that a pathologic correlate of Meniere's disease is endolymphatic hydrops, but current understanding of the pathophysiology of this is a little bit more complex. What is your current understanding of what the underlying mechanism of Meniere's disease is?
So Meniere's identified this constellation of symptoms called Meniere's, but there was actually no anatomic correlate until almost 100 years later. So Hallpike and Kearns in England and Yamakawa in Japan in 1930s or 40s, they were the ones who first said, wait a minute, Meniere's disease patients do have a histopath correlate. And this correlate is an enlargement of endolymphatic space inside the inner ear. So if you remember, the fluid in the inner ear actually have compartments. There is, for example, in the cochlea, scala vestibuli, scala tympani, and in between scala media. But these are also filled with different fluids. So scala media or cochlear duct has endolymph, and surrounding that is perilymph. And it continues into the vestibule where there is sacuutricle containing endolymph. And then the endolymphatic duct, obviously, towards the endolymphatic sac in the back. So it's this fluid in the endolymph, in the cochlea, vestibule, semicircular ducts, endolymphatic duct and sac. This space is big. And so these discoverers of this phenomenon said, this space is big, and that was called endolymphatic hydrops. The current understanding, though, has evolved. In the beginning, people thought, it's hydrops. It must be distended and under pressure. And this is sort of analogous to back in the day, people thought it's like glaucoma when the eyeball is full of fluid and it's high pressure. Or hydrocephalus in the brain, there's a lot of fluid in the ventricles and it's under pressure. And that was the feeling with endolymphatic hydrops. But the understanding later on is, I don't think this really is under pressure. And I can show you a recent paper that came out of the otopathology group that showed this. It's a beautifully designed study. Okay. So this was a paper that was published end of 2025. So just came out. And this was the paper that showed that hydrops really is not a distension or high pressure phenomenon. So what they did was they looked at the cochlea under microscope of controls. So they have no problems, no hydrops. So that's this figure in A. So just look at the cochlea for a second, and you can see here's the cochlear duct or scala media containing endolymph, and that's the normal little triangle, that's normal. And on either side is scala tympani, scala vestibuli, full of perilymph, the dominant fluid compartment. So in each spiral of the cochlea, you can see that's normal. Then in panel B, you can see that that little triangle has now kind of ballooned out to make this giant space. So this is endolymphatic hydrops. And in panel C is also someone with endolymphatic hydrops, but it's secondary from something else. But also that little triangle has ballooned out. What they did here is they actually labeled the cells on the lining of the cochlear duct of the little triangle and these ballooned out spaces. They looked at cell spacing. So that's coded in this kind of green to blue to dark purple spectrum, and cell count, which is in this sort of orangey red spectrum. If we look at cell spacing, you can see that around the little triangle in controls, it's kind of like a blue, and it's sort of still kind of like a blue when it's ballooned out, and still sort of like a blue when it's ballooned out in secondary hydrops. So the cell spacing really doesn't change whether it's distended or not. The cell count in a control is really, not a whole lot of cells, but when it's ballooned out, it's actually more orange. You see that? So that's a higher cell count. Secondary hydrops also, higher cell count in the red spectrum. So what this is saying is that, forget this for a second, if you think about a balloon and you blow up a balloon and you look at the little particles along the surface of the balloon, the more stretched out it is, the sparser the particles should be on the balloon surface, right? Should not be just the same or even denser. That's under pressure and blown up. If here, what it's actually showing is the cell spacing is exactly the same, but there are more cells, this speaks to a hyperproliferative. There's actually more cells now in the lining than before. This argues that number one, it's not really distended and stretched out with this exact same number of cells on the surface. And number two, it's actually hypoproliferative. And the analogy may be closer to like a kidney, where there are more cells now to compensate for the need to, do drainage or what have you. One kidney grows bigger when one gland is atrophic. So this is really the first time that there is some proof that it's really not under distension, but in fact, it's proliferative. And so this speaks to the theory now that when the endolymph space is big, it actually may be a compensatory mechanism. And I will share with you a different slide that shows this theory. This was what people used to think, that hydrops is the center of everything. And it could be from different causes, but the end result is that there is hydrops and distension, and then you get a bunch of symptoms. But in fact, that's not the case anymore, is the proposed theory. And the proposed theory now is basically, it's an inner ear homeostasis failure. And that failure has to do with a failure of the endolymph system as a whole. And that's what leads to Meniere's disease. And what leads to this endolymphatic system failure? It could be a whole bunch of different things. And in fact, the endolymph system is trying to compensate for it. So you can have, problems with the endolymphatic sac. You add on stressors. Your body actually tries to compensate by making the endolymph space kind of function regularly by hyperproliferating. And when that finally gives out and the compensatory mechanism fails, that's when you develop this irreversible failure and you get Meniere's disease. So that is the most current theory in investigation in the field of Meniere's with hydrops.
If I understand your figure correctly, the underlying abnormality is some endolymphatic sac deficiency, and that might be hypoplasia or degeneration. And what we see in terms of endolymphatic hydrops is kind of a reaction to that, a hyperplastic reaction to that. And when it's failed, the patients are symptomatic.
Exactly.
Is that right?
Exactly.
Awesome. So I imagine then there is some way to image these various manifestations, whether that is the endolymphatic hydrops itself or the hypoplasia of the endolymphatic system. Can you go over with us recent developments on the role of imaging in the diagnosis of Meniere's disease?
So I leave this slide up because I want to show how most radiologists in the last probably 20 years or so we've been focused on looking at this distended space because that's the one anatomic marker that indicates something is wrong with the endolymphatic system. And this is the marker as defined by Hallpike and Kearns back in the day. That imaging is on MRI, and it was discovered in Scandinavia along with authors from China that if you inject gadolinium and you wait long enough, IV GAD would gradually permeate into the perilymph, but not into the endolymph. So then if you do the correct sequences to image, you'll find enhancement in the perilymph space, but not endolymph. Now, for the first time, you can actually distinguish between these two fluid entities within the inner ear, as opposed to just how we usually see fluid all looks bright on a heavily T2-weighted sequence. So this is the first time. And you can also inject through the ear itself, through the drum, and then it permeates through the round window and it gets in. So two ways, although now we usually do IV. And then in Japan, that really took off because the Japanese group, Naganawa, they really developed this and saw this in humans for the first time and put it in the context of imaging of the hydrops for Meniere's disease. So all that is looking at this reactive, we think, this reactive phenomenon where this space got big. So the biggest development our group has done at Mass Eye and Ear is to say, okay, that's fine. And we can have that be complementary with diagnosing by clinical diagnosis, which is how Meniere's disease has been diagnosed, for as long as we could remember. Major criteria, minor criteria, all clinical. Now we have an anatomic radiologic adjunct, which is this hydrop seen on MR. But our group now focuses on looking at the underlying type of abnormality in the sac led to this need for compensation. And the underlying mechanism, as you mentioned earlier, what can lead to an endolymphatic sac deficiency are two ways. So going back a little bit, the first paper that came out of Eye and Ear was one where we looked at histopath and CT. So they found that it turns out the endolymphatic sac can be problematic in different ways. One way is you were never born with a functional and normal sac. Or two, you were born with a normal sac. It's normally developed, but over time, the lining degenerates. So that's the two different endotype, if you will, the underlying mechanism of disease with the corresponding phenotype, which I will mention now. So either you were born without it, so it's endolymphatic sac hypoplasia, or you were born with it fine, but it degenerated, so it's endolymphatic sac degeneration. So now we cannot see the endolymphatic duct or sac on imaging, definitely not on CT, not even really on, 3T MR, or I don't know about 5T, 7T. You cannot see it. Sometimes if the sac is huge, you might see it with a little sediment level, but by and large, no. But the discovery in that paper with histopath and CT was that the endolymphatic duct and sac is surrounded by the vestibular aqueduct. And so you would imagine that the sac and duct develop in lockstep with the development of the bony channel around it. And it's known that in fetuses, the endolymphatic duct and sac are not yet completely formed, and it kind of adopts this straight front to back orientation. And the vestibular aqueduct around it is also straight front to back. And this was known back in the day of tomogram with Valvasori. They could see that it's kind of short and stubby and front to back. So in a para-sagittal plane. And as the fetus develops, and even after we're born, it keeps developing. It gradually goes from front to back, gradually to more and more and more horizontal till we get to this point where it's kind of oblique a little bit, which is what we're used to seeing on CT. And the theory is the brain keeps developing, whereas the Oda capsule is already fully developed at birth. And so it kind of pulls laterally as the sac develops, and along with it, the bony channel gets more horizontal. So now there's a way to figure out if someone actually had an arrest in development of the sac or not. Because if the vestibular aqueduct looks short and stubby and front to back, you can say, oh, it kind of got arrested in this fetal morphology, which corresponds with the underlying sac is hypoplastic. Whereas if the vestibular aqueduct is kind of side to side, this person is either just a normal person, or if they have Meniere's disease, then they've got to have a normally developed sac that later on had the lining degenerate. So by looking on CT and looking at the orientation of the vestibular aqueduct, we know if a person has Meniere's disease, which type they have. Is it the endolymphatic sac hypoplasia type, or is it the endolymphatic sac degenerative type? So that's now how we diagnose Menière's and give a little bit more about the underlying phenotype on imaging at AJNR. So we do MRI to look at the eye drops, and we also look at CT to look at the orientation of the vestibular aqueduct to give some idea of the underlying endotype and phenotype, because that has prognostic implications.
Awesome. So let's talk a little bit about your paper on the CT appearance and the development of the vestibular aqueduct over age, and how you really define a cutoff for what is considered hypoplastic or not. First of all, the context: the patients that are undergoing CT have a suspected clinical diagnosis of Meniere's, right? And so that's the kind of patient population that we should be thinking about when considering whether to look for this abnormality, right?
So I would say it's unusual that patients get standalone CT. Most of the time, they have Meniere's, they will get the eye drops MR, and they sometimes get a same-day CT. Once in a while, they may not need to see the eye drops because they're so confident, but they need to know the phenotype, endotype phenotypes, and that's when they get maybe only the CT, but not as commonly.
So what did you do for this paper on the developmental trajectory of the vestibular aqueduct?
Yeah, so I can show you just a few slides as background that leads up to this project. Okay, so this is a CT, axial CT of the right temporal bone in a cadaveric specimen. So you can see here's the vestibular aqueduct, and that's normal, how we expect it, right? We see this all the time. These are the limbs of the superior semicircular canal. Behind that is the vestibular aqueduct, and I always say it's almost like hands in a pocket. So it goes closer to horizontal, side to side. And in the front, you see that little part that goes in. That's the isthmus of the vestibular aqueduct, and it makes a turn. So it's almost like a hockey stick turned on the side. So the stick part that you hold on to with your hands, that's the main part of the vestibular aqueduct, or we've called that vestibular aqueduct proper. And the part that actually hits the hockey puck is the isthmus that goes in towards the vestibule. So aqueduct proper, we hold on to that. Isthmus is the part that hits the hockey puck. So normally, that angle between the aqueduct proper and the isthmus ought to be closer to 90 degrees, right? Because it would be kind of horizontal. It makes a bend. It's close to 90 degrees, that angle. And we've coined that angle the term ATVA, angular trajectory of the vestibular aqueduct. And that's what we're measuring. So if that is closer to 90 degrees, that's normal. Fully developed endolymphatic sac underlying that. And that was shown in the paper. And to be precise about it, it's not actually close to 90 degrees. What we found is this should always be at or below 120 degrees. So now you can see this patient on the right of the screen has that normal trajectory, right? So the stick that is getting held onto by hands is kind of side to side. On the left, you can see that that part is kind of front to back. And that is the fetal orientation. And you can imagine now the angle, the ATVA, is no longer close to 90. It's closer to 180 degrees. And in fact, in the paper, it's been shown that it's at and over 140 degrees. That's when it's considered fetal. So a fetal ATVA is greater than or equal to 140 degrees, whereas a normal adult orientation is less than or equal to 120 degrees. So that is a normally developing fetus on the left and a normally developed adult on the right. But if you tell me that both these patients who got CT scans here have Meniere's disease, then now I can tell you about the underlying endotype phenotype. The one on the left has an underdeveloped endolymphatic sac. So this is the hypoplastic endolymphatic sac endotype phenotype. The one on the right has a fully developed but probably degenerated endolymphatic sac, and that would be the degenerative type of Meniere's disease. So that's how we endotype them. The one on the left, hypoplastic endotype, HP. The one on the right, degenerative endotype, DG. So if you look at a CT scan of someone with Meniere's disease and you see these different orientations, you can call the underlying endotype phenotype of Meniere's disease. So ATVA is our surrogate for identifying endolymphatic sac status. Now, the problem is we don't really know how early we can call this because they develop for a while. So that was our project. And what we did was we actually looked at scans in early years of life. It turns out that it's never been described before, but the vestibular aqueduct keeps developing. So it's not fully developed yet at birth, but it keeps evolving. But according to this heat map, you can see that the light colors over here are early age, darker colors are later age. And you can see it kind of gets from, this fetal above 140 degrees in early age to now greater than 120 degrees in the later age. So the optimal cutoff that we found was just about by age 5 or so, they should be developed. But if we want to be on the safe side, it's about age 12. So above age 12, if you see the vestibular aqueduct is front to back, you can be pretty confident that this is an underdeveloped endolymphatic sac, and it's not going to continue to develop anymore further on, and can say this is someone with probably a hypoplastic endolymphatic sac. But in the early years, especially under age 5, hold off of saying that because we don't know yet if they may continue to develop in the coming years. So we cannot confidently call hypoplastic endolymphatic sac under the age of 5.
Very interesting. Do you know if it's known, can you be asymptomatic with a hypoplastic vestibular aqueduct? Like if we see this incidentally on a patient not undergoing workup for Meniere's disease, should we make mention of that?
Yeah, so that's a very interesting question because I have noticed off and on now since our research that I see this hypoplastic shape in sinus CTs, head CT, CTA, because they're so thin now. You see all of it. And some of them don't seem to have symptoms, but of course, it may just not be in the chart. Patients may not have mentioned it. We are working on a paper now actually on syndromic inner ear developmental syndromes. And we see these hypoplastic orientation of vestibular aqueduct now. So the interesting part would be longitudinally following them to see if, even if right now they definitely don't have Meniere symptoms yet, will they develop it later? And it's possible because it's a matter of when the compensatory mechanism fails, or maybe they haven't even started developing compensatory mechanism now. So if we were to do an MR on them now, they may not have high drops, but it may develop later. So that would be something interesting to look into in the future.
I have a practical question in terms of accurately measuring the ATVA. You want to be on an axial image that is parallel to the plane of the lateral semicircular canal. And at what level are you actually measuring this? And, where do you draw your lines?
Yeah, we talked about our methodology in our paper, but I will show you this CT scan. This is as if we're scrolling through a CT. So you can see that we want to only look at CT axials when it's reformatted so that it's parallel to the plane of the lateral canal. And that's not only for the purpose of measuring ATVA, it's for all comers. You just always want a standardized way of looking at axial CT temporal bones. So this is pretty good. It's not completely perfect, but it's pretty good. So we see that. And that's the first step. We want to be looking at the correct axials. Now we look at the vestibular aqueduct first, and that's how we look at it. It's really hard to see the isthmus portion. It's almost invisible. But we always know, based on histopathology and on slides we looked at, the isthmus almost invariably exits the vestibule at 14 degrees. And it's 14.3 degrees, but for all practical purposes, 14 degrees. So now we don't even try to look for the isthmus because it's really hard. Maybe on a photon counting once in a while. We look at the back of the vestibule, and what we do is we draw a line. So we make a line that's parallel to the back of the vestibule, and we use the angle measurement function, and we just blindly say 14 degrees off of that. So we have a line going back parallel to the vestibule. We make a line 14 degrees counterclockwise from that, and now we set it on every image of the CT. We know that's what the isthmus looks like, trajectory, how it should be oriented, and that's the part hitting the puck. And now we do a different angular function. One line is parallel to this vestibular aqueduct proper, and we see where it intersects that isthmus, and we have the ATVA. So that's how we measure ATVA. We make a few lines. The first one parallel to the back of the vestibule. Second one, we just know it's 14 degrees counterclockwise from that. And
on the right ear, right?
This is the right ear. So we swing in medially. So counterclockwise for the right ear and clockwise for the left ear, yeah. And then we take that and we look for the angle between that line and the vestibular aqueduct. So that brings us to the point where it's really cumbersome and it's really hard to do. Another paper we've published is we have a surrogate for that, which is it turns out that the retrolabyrinthine bone tends to be very, very thin when the vestibular aqueduct has a fetal orientation. So rather than trying to do this complicated measurement and finding this line and that line and a third line, we just look at the bone behind the posterior canal. So here you can see the posterior semicircular canal, right? It's right around here. And we just look for any point that's the thinnest that's behind it, between the posterior wall of the posterior canal and the back wall of the petrous apex. So for example, here I say, okay, well, let me scroll all the way around, and we don't want to measure it where there's the operculum because that gets confounded. We want the entire thickness. So I would probably here pick right around here. And now I put in a ruler and I just say, okay, back wall of the posterior canal and the back of the petrous apex. And our paper showed that anytime it's below 1.2 millimeters, that's thin. And you can see a fetal orientation vestibular aqueduct in that scenario and hypoplastic sac. Whereas if it's thicker than 1.2, it's almost impossible for that patient to have an endolymphatic sac hypoplasia. So rather than doing all this measurement, the easier way is just to look at this retrolabyrinthine bone thickness. So we published on that. The benefit of that too is now you can translate it over to MRI. So if you get an MR for hydrops in a patient, you can immediately diagnose, is there hydrops or not? And at the same time, you measure the retrolabyrinthine bone thickness on the heavily T2-weighted sequence, the Drive, the KISS, the Fiesta, whatever you can just measure that. And if it's really thick, you have basically excluded the hypoplastic endotype phenotype. But if it's thin, it could be either way, and you could then recommend a CT to do a more precise measurement of the actual vestibular aqueduct.
So if I have that right, if we see retrolabyrinthine bone thickness less than 1.2 millimeters, and we can suggest that this is associated with a fetal or hypoplastic vestibular aqueduct morphology, which is associated with the hypoplastic endotype of Meniere's disease in an appropriate clinical setting. Would that be fair?
It would be fair to say that there is a possibility that this is hypoplastic. It could still go either way, but there's a higher chance. Whereas if it's thicker than 1.2, then it's very, very slim chances that it's hypoplastic. So it's more that the thick one rules it out, but a thin one doesn't rule out a degenerative type.
Got it. So any last words for our audience on take-home points from your two different studies on the role of CT in Meniere's disease?
I guess take-home points would be, number one, it sounds super complicated, and there was a lot that just happened with the discussion here. But the main things are, number one, we know we can diagnose hydrops on MR. We think that's a compensatory mechanism. But from an imager standpoint, that is the one thing we can say, okay, this jives with a Meniere's disease, so symptoms. But two is we can do better than that. We can look on CT and on CT or MR with the retrolabyrinthine bone to give that Meniere's patients an underlying endotype phenotype. And that's important because they have different prognosis. They present differently, earlier onset, later onset, bilaterality. So there's difference with patient counseling. So that's useful information for us to include in a report. So I think that's something you should consider adding to your imaging report to talk about that, because it makes a difference for the patient. And the third thing I really want to emphasize is that from now on, because we know Meniere's disease patients are not all the same, they're actually different. Research should be approached in that way. We should not do Meniere's disease saying, oh, let's analyze Meniere's patients about, age of presentation and do they respond to treatment. They should be subgrouped into these different endotype phenotypes because they are different and their presentation may be different, treatment response may be different. And if they're lumped together, you end up having noise in your data set. I think all research from now on ought to be done recognizing that it's not all the same. Meniere's disease patients are not all the same, and they should be analyzed separately in these two separate subgroups.
Terrific. Thank you so much for joining the AJNR podcast today, Amy.
Thank you, Francis. Thanks for your time.
Listeners can check out Dr. Juliano's papers in the AJNR. We'll put links to the articles in our show notes. Thanks so much for listening and viewing the video on YouTube and Spotify and other platforms. We'll see you next time.